As everyone in the audience will be aware, type 3 AC joint dislocations reflect a complete disruption of the AC and coracoclavicular ligaments, but an intact delta pectoral fascia, which distinguishes them from the higher grades of injury. The management of these injuries has long been controversial. The two areas of controversy that I'm going to touch on today are really the management of acute injuries, non-operative or surgical, and then what is the appropriate surgical technique for the main chronic injuries. Debate has been going on for many years about non-operative versus surgery, and this is reflected in a number of surveys that have been taken in the US of physicians. In the 1970s, the directors of residency programs were surveyed, and the vast majority supported a surgical approach to an acute AC joint dislocation type 3. In the 1990s, the pendulum had basically swung the other way, and over 70% of surgeons recommended non-operative treatment. And this has continued as recently as 2007. Nissen and Chatter published a survey looking at specifically members of the American Orthopedic Sports Medicine Society and found that 86% of them recommended non-operative treatment. Problem with non-operative treatment has been really there's no standardised protocol. Most authors recommend a sling or an arm immobiliser for between 2 to 4 weeks or until pain subsides. The majority of papers nowadays don't recommend braces. The immobilisation is usually followed by physical therapy in the form of range of motion exercises. When a painless range of motion is achieved, then a strengthening program and avoiding heavy lifting and contact sports for between 2 to 3 months, or at least until good strength is achieved. Interestingly, Glick in 1977 showed that there is a paramount importance to a good strengthening program for people who've suffered this injury. He surveyed 35 patients who were active sportsmen, including professional sportsmen. He found none of them had a disability at follow-up, but those that had missed out on a good strengthening program often had residual pain. There's been a large amount of research on non-operative versus surgical management. Many papers published in the literature. Of interest, Larston and Taft in the 1980s compared either AC joint fixation or a coracoclavicular screw with non-operative treatment, and they really found satisfactory results in both groups at follow-up, and in fact a shorter rehab for the non-operatively treated patients. Bannister in 1989 did the first randomised controlled trial with 4-year follow-up, and he had a homogeneous group, but 40 or more of the patients had type 3 AC joint dislocations which were treated acutely, and the vast majority of those patients had very similar outcomes, whether they had an operation or not. And in fact, a full range of motion was achieved more quickly in the non-operative group, and return to sport and work was quicker in the non-operative group. Phillips in 1998 did a meta-analysis of the literature available on acute injuries of this nature and compared non-operative treatment with various surgical techniques. And he found overall the satisfactory results in both groups about the same. He found a higher complication rate in the operatively treated group. He found, in addition, a return to activity and pain relief was about the same. And most of the non-operative patients had better range of motion and strength, which approached more normal. There have been criticisms of all these studies, in particular that, as I spoke of before, there is no standardised protocol for rehab. A lot of these papers are quite old now, and a number of the surgical techniques have moved on, and perhaps we'd find better results with the more modern reconstructions where we reconstruct the coracoclavicular ligaments in particular. We look at the surgical indications. As I said, in the acute injury, there are relative indications only. Authors talk about young patients, heavy labourers, elite athletes, multi-trauma patients, those are concerned about cosmesis. But even in elite athletes, a paper by McFarlane in 1997 showed a group of professional baseballers treated non-operatively did well and returned to their sport. In the chronic situation where surgery is more often indicated, authors point to failed non-operative treatment with pain and instability. There's about 75 different surgical procedures described for the AC joint. They fall into 4 broad groups these days. AC joint fixation with K-wires, which Mr. Lyons can tell us only too well has failed dismally, with the preeminent paper written on this by him in 1990 showing migration of pins and wires in the shoulder. Hook plate has now really taken over this space and is very popular for acute injuries in Europe. Coricoclavicular interval fixation with previously Bosworth screws, but now suture loops and buttons for the acute injury. The classic Weaver done and its modifications for both acute and chronic injuries. And then the most popular recent innovation being ligament reconstruction with hamstring tendons. Hook plates really being the principal AC joint fixation technique that nowadays are not without their criticisms. They are quite popular in Europe, but Sim in 1995 showed a 50% complication rate when he treated acute dislocations with hook plates. The majority of these were infections, but he did have plates that bent, and as you can see, plates migrating up through the acromion. Gerstner, more recently in 2008, did a study and claimed the hook plate was superior to non-operative treatment, but those papers are really the exception rather than the rule. Bostrom Winhamry published in 2010 a technique comparing modified Weaver done using a hook plate to stabilise the construct versus a PDS braid passed around the coracoid and the clavicle, and found the hook plate patients had more pain, a worse constant score, and of course required a second operation to remove the hook plate. He really came down on the side of avoiding hook plates. Coricoclavicular interval fixation, as I said, was first described with screws, and the Bosworth screw is the one I was familiar with when I was training. Nowadays it tends to be suture loops and endo buttons. And Huang in 2009 described a suture loop technique in 17 patients with acute injuries, where he passed the suture loop under the coracoid and through drill holes in the clavicle. He claimed good results in all of his patients, but we've all seen papers or instances where the sutures cut through either the clavicle or the coracoid. Of course, in shoulder surgery, if someone can do it open, someone else wants to do it arthroscopically. And Di Bardino in 2009 published a paper performing an arthroscopic coricoclavicular interval fixation. He visualised the base of the coracoid with the arthroscope through the bursa, resected the tissues away from the base, and then passed a guide wire followed by a cannulated drill through the clavicle and into the base of the coracoid, used an endo button on the coracoid side and then a special washer on the clavicle side, which he tied the construct over. He claimed excellent results in all 10 of his patients. And what he can do, someone else can do better. So Saltzman in 2010 used a double bundle technique. He sought to reproduce both the conoid and the trapezoid ligaments with 4 endo buttons instead of 2, and claimed again excellent results performing this procedure arthroscopically, visualising the coracoid through the bursa. In fact, though, if you look at his paper more carefully, 35% of the patients had a loss of reduction. CA ligament transfer has been the hallmark really of AC joint reconstruction for many years. The Weaver done and all its modifications, modifying it with sutures, suture loops and tendon grafts. Most papers claim good to excellent results, although particularly when it is not augmented with a screw or suture loop. There has been a 20% loss of AC joint reduction in some papers, and recently biomechanical studies have questioned the strength of this construct. Again, just to show that anything that can be done open can be done arthroscopically in shoulder surgery. Lafosse in 2005 published a paper performing an arthroscopic Weaver-Dunn technique for both acute and chronic AC joint dislocations. He identified the CA ligament from its attachment on the coracoid to the acromion, and then passed a suture from the base to the acromion. He then released the ligament off the acromion, identified the undersurface of the clavicle and roughened the undersurface. He then had passed the suture through drill holes and tied it down. Again, he claimed excellent results in all his cases. Just skip on from this fairly quickly. I know we're going over time. The main issue with this busy sort of slide is that the majority of authors have shown that a simple Weaver-Dunn technique has only about 25% of the strength of the intact coracoclavicular ligament complex. And so a number of modifications like suture anchors placed in the coracoid and tied over the clavicle have been used to increase the biomechanical strength of the construct, but they still don't really approach the normal CC ligament complex. And this has led to ligament reconstruction, just basically copying our knee boys and stealing their hamstring tendons. Jones was the first to describe a ligament reconstruction using a hamstring in 2001. He originally performed this surgery for a failed Weaver-Dunn technique and passed semitendinosis around the coracoid and over the clavicle. Carafino and Manzocca in 2006 adapted this further, and now there are multiple modifications. Different tendons like tibialis anterior are also being used. The most recent article I could find was by Carafino and Manzocca, just to show how far this technique has gone. In 2010, they took a doubled semitendinosis graft. They passed it through a bone tunnel in the base of the coracoid. They then passed it through two separate drill holes in the clavicle and fixed both of those with interference screws. And then they used the residual tendon to pass over the top of the clavicle and suture or fix into the acromion to reproduce, they said, both the coracoclavicular ligaments and the superior acromioclavicular ligament. They had 17 patients and claimed improved pain and function, and an American Shoulder and Elbow Society score which improved from 52 to 92. They did, however, have 3 failures, but I couldn't really find out quite what the failure was. They just said it wasn't from fracture or erosions. The drive for this sort of ligament reconstruction has really been the biomechanical advantages of this sort of technique. Reconstruction using hamstrings has been shown to have the best strength and comparatively the closest strength to the intact coracoclavicular ligaments, particularly if you reproduce both conoid and trapezoid, and is superior to any sort of Weaver-Dunn, including an augmented technique with the Weaver-Dunn. So in conclusion, this is just a very fast run through the topic. Acute type 3 AC joint injuries, based on the literature, should in the majority of time be treated non-operatively. There are really few surgical indications. When it comes to surgery, there is really no optimal technique that's yet to be established. And whilst there are superior biomechanics have been shown with ligament reconstruction, there are yet to be enough papers to establish a superior clinical outcome for this procedure.